Let's crack hyponatremia. What is hyponatremia? Hyponatremia is a serum sodium less than 135 milliequivalents. The trick is to find out why. The first step in evaluation of hyponatremia is assessing the serum osmolarity. If the serum osmolarity is high, it is a hypertonic hyponatremia. It is usually secondary to a hyperglycemia. If the serum osmolarity is normal, it is usually a pseudo-hyponatremia, mostly associated with a hypertriglyceridemia or a hyperproteinemia. The third is a low serum osmolarity, which is a true hyponatremia. The next step is to assess the volume status. If the patient is euvolemic, it is a euvolemic hyponatremia. If the patient is hypovolemic, it is a hypovolemic hyponatremia. And if the patient is a hypervolemic, it is hypervolemic hyponatremia. Now, how will you find out this? Based on history and clinical examination. If the patient had repeated episodes of vomiting, diarrhea, and clinically if the patient looks dehydrated, it is a hypovolemic hyponatremia and the treatment is always fluids. If the patient has a normal volume status, it is a euvolemic hyponatremia. It is usually associated with SIADH. It can be associated with thyroid dysfunction or an adrenal insufficiency. The treatment is usually treat the underlying cause, and as an SIADH, you can ask them to restrict fluids. If the patient's volume status is hypervolemic, that is clinically you see bilateral pit and pedal edema or anosarca, it is usually associated with renal failure, heart failure, or if it is associated with the cirrhosis of liver. The treatment is diuretics and sodium restriction.